Would the panelists introduce themselves? Thank you very much. From proximal to distal.
Hi, I'm Sedina Madamale from the Kolibu Teaching Hospital and the University of Ghana Medical School. I'm a fourth-year radiology resident. Thank you.
Okay, I'm Dr. Nitra from Bangkok, Thailand. I already introduced myself.
Ray Osarogiagbon, Memphis, Tennessee.
Carlijn van Aalst from Erasmus Medical Center in Rotterdam, the Netherlands.
Aigner, thoracic surgeon from Vienna, Austria.
So thank you all for introducing yourself. We're starting with a question for the audience first, then bring it to the panel debate. So after all we've heard about incidental pulmonary nodules, whether single or multiple, what you think is the relative importance of detecting such incidental nodules? This might be different scenarios that you work in. Are reported and or manage nodule depending on their size and also the clinical history. I just report and manage the nodules, and this is independent from the clinical history in incidental nodules. Or I report only incidental nodules that are larger than 6 millimeters. Or finally, I report and manage nodules of any size, independently of clinical history. So it's a sharp figure, isn't it, here? So when we shift from lung cancer screening to incidental nodules, we have to take into account more factors than just the size, right? Because there are connective tissue diseases, interstitial lung diseases, COPD, bronchiectasis, and so on. So we now move to the panel opinion. So when you detect nodules and you stratify them within the incidental workflow, so with the normal clinical practice, do you think that information can be picked up from those already post-test stratification, right? You already have a post-test, and add the high-risk information. You apply the inclusion criteria, for instance, of one or the other guideline to pick up from this population and see how many of these nodules would have been indeed eligible for lung cancer screening, dividing also them between those that then become cancer and those who don't. We have heard from Dr. Osarogiagbon, yeah, Ray, yeah, Ray, Dr. Ray, that they have a program dedicated for that. But I would like to start proximally to distally with your opinion for that.
Okay, so for Ghana, when we report all nodules that we see on our CT scans, and we also recommend the low-dose CTs for patients at risk. We implement satisfaction of search such that we are able to pick up nodules of varying sizes, report them, and then follow up. Yeah.
So in our country, I think for the report first, we're gonna report all of these nodules, but we may be classified as the nodules such as less than 6 millimeter, maybe no need to follow up. And for the dominant nodules, in Thailand, I think there is some incomplete information during we have the CT. So sometimes if we look at the CT and the patients like have the COPD like emphysema, we consider as a high risk. And then we maybe suggest according to the radiologic findings which we see in the CT. But if we don't have any information, we just tell them that if the patient is a high risk group, they should follow up based on the risks of the patients. And most of the nodules, in my experience, I think most of the incidental nodules are not fit to the screening groups. Mostly, they did not have any relates for the smoking or something else. But maybe, as I mentioned, maybe air pollution that we cannot notice. And even though they're smoking, we don't know how much that they smoke. And in Thailand, some people, they did not smoking like a cigarette as a pack. They do it by themselves. So we don't know how much of the degree that they smoke.
So just to add some context to this, what would you prefer, Ray? For example, if you had to choose between a lung cancer screening program or incidental lung nodule program, it sounds like from your data that the incidental lung nodule program is more efficient, I guess would be the word. Do you agree with that, or do you think just selection bias, and since all those people already have nodules, there's not really an incremental advantage to that? What would you choose?
You ask me?
Yeah, I would say, first of all, I think that's a false choice. I think that the two are necessary. Because if you think about it, screening is really focused on people who are apparently healthy, who meet your criteria. So basically, you're saying you're trying to rescue people who totally look healthy, but came to do a test just because we told them they meet certain criteria. Whereas the incidental nodule people have come because they had problems. It just happened to be something different, which is why we happened to get the test. So I think it's important for us to recognize that we're talking about two different segments of the population. We must not kind of let ourselves get trapped into making these false choices. Because if you look at the people who are in an incidental nodule program using current U.S. Preventive Services Task Force criteria, it's about 25 to 30% in my cohort who would qualify for screening. The majority who do not qualify for screening, the reasons are they're too old, too young, didn't smoke enough, they didn't smoke at all, or quit too long ago. But they got lung cancer anyway. So how are you going to find those people? Is why we really have to do this. But I'll go past your question and say that in my vision of what the future holds, really all that we have done with Nelson and the NLST is to prove a hypothesis that by doing CT imaging in certain people, you can find lung cancer early enough to make a difference. What we have not done is to ask the question, can you find lung cancer early enough in whole populations to make a dent on all of lung cancer? I think it's important for us to remember that. Because I think now that the hypothesis is proved, we now need to push on to the real question, which is, how are you going to modify your technology, advance your knowledge to the point where you can routinely find lung cancer early without these artificial criteria that, we use? How much do you smoke? How old are you? Basically, we want to be able to figure out a way to get pretty much anybody out in populations who is destined to get lung cancer. We're not there yet, but clearly that's a destination we need to be trying to get to.
One question maybe for Carolyn. Do you think there's a difference between truly incidental lung nodules, meaning let's say you get a CT angiogram of your coronary arteries and you find a nodule, or a symptom-driven finding, somebody who's sicker or going to the doctor for a particular symptom and then is has an incidental lung nodule. Are those two different entities, and should they be managed differently, or should they be managed in the same way?
Yeah, that's a good question for a non-virologist or pulmonologist. So first of that. To be honest, I don't really know. I think that based that you have to look at the nodule characteristics. So that is first of thing, because that is visible and that's measurable. And then you have, of course, your lung cancer risk, and that you have to deal with both part of informations, how to deal with that at that moment, and whether you have to need more surveillance, or that you can act on that moment. But I guess I think that more insight is also needed in the incidental findings, because now what was said, we now know that we can early detect, that we can early treat. But how is that in a general population, and how is the balance between harms and benefits in different risk categories or different patient populations? So that we need also to report that to get more insight in it.
Maybe one question for Dr. Aigner. This paradigm of multiple nodules, where the largest nodule is the governing principle in follow-up, almost reminds me of triage, where you arrive at a car wreck scene and you have multiple injuries. And maybe the loudest person is not really the sickest person. Do you think there's enough evidence to guide principle that the largest nodule in a multiple nodule setting is the one that you have to worry about the most? Or do you think there's something morphological about a particular nodule that should take precedence over that?
Well, I think this management strategy is the best based on the best evidence available. There's no better evidence there, but of course the tumor biology, if it's multiple different synchronous lung cancers, can be entirely different, and probably the smallest is the most aggressive one, who metastasizes first or grows faster than the largest lesion. So that's why I think it's important to obtain more systematic data on that, to gain more insight on tumor biology, and if possible, obtain histology of as many lesions as possible, to get a clear idea of the aggressiveness, and then guide the treatment strategy according to that. So maybe one additional comment regarding the discussion incidental versus screening. It's of course, like Raymond said, two different pathways, how the patients versus seemingly healthy people come in. But in the end, the decision making should be both groups the same, based on radiological appearance plus the clinical factors. Of course, the clinical factors will greatly vary between these two groups. That's why they came in via different pathways. But the algorithms for decision making should not be different, in my opinion.
I think Ray wanted to comment on that.
Yeah, I'll just throw in, we presented an abstract at last year's World Lung Conference that sort of shines a little bit of light there. We looked at people diagnosed with lung cancer through our 2 early detection programs, screening and nodule. And we just asked the question, what was the lobar location of the nodule, and what was the lobar location of the cancer? And what we found was it was discordant in about 30% of the patients in both programs. So using the T0 scan as the index. And what we also found was that the outcomes of the patients with the discordant nodule/cancer was worse than the patients with concordant, for what it's worth. So yes, I think this is an important issue you raise, and the question is, what's going on? Is it that somehow clearly with lung cancer screening, we've identified a group of people who are at pretty high risk. We all know that. With the incidental nodule program, what's going on with that is not entirely clear. but it has meaningful implications potentially, for example, in trying to figure out how do you use artificial intelligence to go past the challenges of eligibility criteria to make early detection maybe more feasible in a wider population of patients.
Thank you, Ray, for your enlightening evidence, and indeed. I have a question about that. The 30% of the scrotum lobe, was it more represented within a subsolid nodule, or was that analyzed?
Yeah, that's a good question. I don't, we haven't analyzed that, but that's something maybe I could go back and query. Yeah.
Thank you. So the crowd is already burning on the next question, probably. So we have incidental nodules, and then we have screening, but in the middle of that, we might have opportunistic screening. So it's not really an incidental nodule, but is somebody seeking screening out of the plan, out of the established plan. So is it really happening in your clinical practice? Do you have the feeling of that? Of course, it's a subtle feeling that you might have. And options are for, yes, it is a sizable phenomenon in the workflow, either as a radiologist or a prescriber of the exam. Yes, it's happening. However, it's extremely rare, let's say once a month. Or I have the feeling that it might be happening, but I do not really perceive it within the regular clinical workflow. So I have no data to support my idea. So, or otherwise it is not happening. So the sharp impression is that somewhere in the radiology department, this is happening, right? Whether it is hidden or made it explicit, it is really happening. And this question was actually the introduction for the next question to the panel. So would it be? Yep, sure.
Just wanted to ask the room, how many people think that opportunistic screening should happen or is desirable, to raise their hands? So it's interesting because at least in the COPD world, this is given that COPD experts believe that they should do opportunistic screening. They do CT scans on their COPD patients to look, among other things, for lung cancer and phenotype their patients. So is it more an emphysema phenotype or more a bronchitic phenotype? But I think the room is split as to whether that's desirable.
Yeah. Yeah, and we know indeed that COPD has risk factors in common with lung cancer screening. Probably if you strike a line on the percentage of people that would be eligible, probably most of them might be, or at least as a biological point of view, susceptibility of the lung damage that they receive. So is there any impression from the panel that opportunistic screening might leverage the feeding, Ray, your data, the feeding of then the lung cancer screening programs, or that where those programs are already in place? Or should this be also a data collection that we might be doing, as Caroline is showing, with the platform for the management to inform those places where lung cancer screening is not happening?
Yeah, I obviously I think that both programs are necessary. One is easier to start than the other. The incidental nodule program is actually easier to start because you've leapt forward into you've skipped the question of eligibility criteria, getting that smoking history, which is so hard for us to get systematically in healthcare systems. The Fleischner Society's guidelines apply to people 35 years old and older. So the age spectrum is broader. You don't have to go find these people. There's this concept of lung cancer screening eligible people being hard to get. hard to find. They tend to be in demographic segments that typically don't consume healthcare electively the way we would need for screened people to. The point with the nodule program is they have already come to us. We don't have to go find them. And the issue we're just dealing with is simply when they have come to us and we have received a signal with which we might be able to make correct decisions to rescue them, do we fail in handing off or do we hand off successfully? So the problem with managing lung nodules, of course, is it's a hook and a slice, right? It's a two-way miss. Anybody who plays golf knows that you can't play around if you're hooking and slicing all the time. On the one hand, there is the problem of you don't hand off, and so the thing gets missed until it's obvious. And then on the other hand is you hand off but make wrong decisions, such as overutilize. You know, there are people with low risk and you treat them as if they were high risk, or people with high risk and you don't adequately recognize. So I think that we just have to, it is important. Both programs are important. The nodule program is less implementation resource intensive, but at some point, the two programs then flow forward with the same infrastructure. Ideally, it should be the same teams, right? It is the same, you know, medical information infrastructure that you will probably use to manage the patients once they get enrolled into the pathway.
I understood the question whether it is desirable that patients without a clear medical indication go for a gray CT screening outside of a structured program. Basically, for example, in Austria, we don't have a national screening program, and this is clearly something that's happening in practice, but I don't think that's a good strategy or a good approach because it completely happens in an unstructured way. And we know that also the established screening programs utilize different criteria for indicating the screening process, different age ranges, different smoking histories. So what happens is the problem that might an sort of overdiagnosis might happen, and people are actually harmed by that, and we don't have the possibility to collect any systematic data on that. So I don't think that's anything that's desirable, and really think a structured program for people without a clear medical indication for CT scans, this should happen in a structured screening program. And besides that, for those with indication for a CT scan for another reason and incidental nodules, of course, this is pretty easy to set up a program of systematic workup of these nodules and to treat these patients, because these are already patients in a structured way.
I totally agree with you, and some comments also on that is that when you only or when you use the incidental nodules, it's not without a reason that the screening programs are annually, maybe biannually, for many years. So what about just one scan? What can you see? And maybe also you maybe falsely reassure people because there's maybe now no nodule, but also what do you have to do with that? Is there a real balance between harms and benefits in acting on that nodule? So I think that indeed you need really a structured way, but not ignoring incidental nodules.
Can I ask a question? Just a number from all the members of the panel. What you consider an acceptable false positive rate for an individual with an incidental lung nodule who goes to surgery? Is it 5? Is it 10? Is it 15? Is it 25% from proximal to distal? What would be the percentage of acceptable benign resections in an incidental lung nodule program?
Yeah, I think we would say under 10%.
Around 10% or over?
Under 10%.
Under 10%.
I think that was what most data show, that it's underneath 10% if it happens in a structured way, and that's the rate it should be.
I have no number in my mind, but actually before to proceed to surgery, I try to make it sure that is it is appropriate to surgery. But because sometimes in our country, like TB, tuberculosis, sometimes mimics like a cancer. So it's acceptable, but we must assure that we do the best to like follow up or further investigation to make it sure that they need to surgery. But whatever the result, we have to accept that.
And I'll just add that in the United States, that leaderboard I talked about, lung cancer incidence, the lung cancer mortality belt of the United States also happens to overlap the histoplasma belt of the United States. And then there's sarcoidosis and valley fever, coccidioidomycosis. So the vast, I said 7% of the people in our nodule program diagnosed with lung cancer, but the flip side of that is 93% have not been diagnosed with lung cancer. So clearly, if we were just pell-mell, recklessly going in and doing stuff, we would hurt way more people than we would benefit. So that too is part of the reason why the interdisciplinary decision-making structure is so vital. You really do not want the headline news to all these poor people who we harmed.
I would also like to add that so where I come from, we have pulmonary TB also being prevalent. So especially they present with multifocal nodules, and you want to treat the patient for TB and then follow up over 3 to 6 months. Yeah. So I also don't have a figure in my mind to tell if it's 10% or 15%. But then I agree with what my other colleagues have said. Thank you.
And then the endemic infection makes it extremely variable and extremely difficult. We have the data from the K. Lucas as well, right? Mm-hmm. They say that indeed lung cancer screening with endemic TB infection is quite a challenge. And I like you brought the discussion to this topic because we prepared a case just about that for wrapping up the session. And this is the case. Dry cough in a 63 years old woman, never smoker, 175 centimeter tall, 57 kilogram weight. How would you report this chest x-ray? Lungs are clear, whatever is negative here. There is lung opacity, follow up by another chest x-ray, lung opacity, workup by HRCT, lung opacity workup by PET-CT directly, or lung opacity and workup by transthoracic needle biopsy. Not sure whether, okay, more than at least 10 people voted, more. So there is quite an agreement, right? Probably somebody from the back rows saying that lungs are clear, but yeah, it's late and it's almost evening, so we have kind of tired. Yeah. So you can see the lesion in the left upper lobe, right? This is a focal solid lesion. And indeed, the workup, the best workup would be to have an HRCT done. This is the finding. And this is the finding again after 1 month. So what would you do? How would you interpret this finding at this point, and what would you do as a management? Another low dose CT in 3 months, just 1 month has gone. PET-CT, bronchoalveolar lavage, or we go again straight to transthoracic needle biopsy. Almost there. So we equally split between low dose CT in 3 months and PET CT. No, figures are changing. So we have conservative monitoring. Yeah. Okay, so just remember that 50% is about conservative management, which is good after just 1 month, because we don't really know what is going on in the rest of the lung. 29% is suggesting PET CT for metabolic evaluation of this lesion and potentially staging if we already assume this is a cancer. And somebody is going straight for biopsy there. So how would you interpret now this image if you think that beyond that left upper lobe nodule, you also have a lot of mucus plugging around in the lung, especially in the lower lobes. And we remember 175 centimeter tall woman, dry cough, relatively thin and weight. There are risk factors that might apply for chronic infection potentially, right? Is everybody voting 100%? So I think this is relatively satisfactory, right? And yeah, BAL might be indicated to see whether there is a non-tuberculous mycobacteria or mycobacteria in this case. So probably this point was about the management of incidental nodules. Potentially it's quite different as compared to lung cancer screening setting, because we have usually more factors to account for. This is not an asymptomatic subject. This is a dry cough patient who would not be eligible for lung cancer screening, right? And these further findings actually warrant the further inspection, and I would like to leave the word to the pulmonologist here.
Well, the nodule is not changing, short term, but I agree. There's other findings, there's symptoms. So obviously a more conservative approach makes sense, with perhaps some investigation in terms of a potential infection that would allow you to implement treatment.
Yeah, so it seems we are over time. If there is no burning question from the floor, would like to thank our panelists for being on the stage with us and for feeding such an active interaction on still debated topic, right? Because we still have to manage how to have a systematic channel for some of these findings. Having said that, I also thank Louis for having me with him here. It was a great honor.
Thanks, everyone. It's been a great session, a long day.